My name is Justin Gardner. I'm the Wilderness Fellow with Virginia Tech Carilion. I started this program back in September. My program director is here as well, Steph Leroux. She and I have been kind of running this since September. This is the first time we've got FOM credit approval and switched back to Zoom. So sorry for anybody that was stuck in that Google Meet waiting room that didn't exist. So we're going to start off with guidelines on drowning through the WMS. And we've got a couple of the authors here and people that are experts in the field. So Seth Hawkins, Chris Davis, I think Andrew Schmidt should be either here or joining in a minute. And any of you who, if you want to talk now, jump in during the guidelines or after.
Hey, Justin, I'll jump in. This is Andrew Schmidt.
Yeah.
I'm currently pushing ketamine to do a sedation. So I'll just jump in and say hi, that I'm technically here, but I'll jump in and out, but Seth Collins is on as well.
Anything to add before we have our presenter start with the guidelines?
No, just excited you guys are covering this and look forward to the discussion.
So my name is Riley. I am a fourth year medical student from UNE-COM. And I am going to talk to you about drowning. So these are the drowning guidelines. This is the Wilderness Medical Society from 2019. The official article is here. And it sounds like we've got some of the authors on board. So it sounds like Schmidt is busy, but I think Seth Hawkins is here and someone else. Anyways, why don't we get started? So for the first thing, I just want to review how they looked at the evidence. So this was a review study. They looked at a bunch of different areas and topics in drowning and then put their own recommendations to it. Most of the recommendations in the article are either 1C, there's one recommendation that's a 2C, 1B. So that's in the categories of, strong recommendation. There's either some moderate quality evidence or some not so much. And it seems like there was a lot of consensus just from experience that they also involved in making these recommendations. So just to start off, what is drowning? So the mortality in the United States, 3.5 thousand people die every year. And the estimate is that about 5 times that actually experience a non-fatal drowning. And these numbers are a lot worse elsewhere. The prevalence of drowning is really the worst in low and middle income countries around the world, places that need water resources for activities of daily living, washing clothes, walking down near rivers, and where there's just lower education in terms of actual swimming and water smarts. So first of all, the big thing that we were concerned about, or that they were concerned about when they put these guidelines out, was terminology. So there's a bunch of different terms that have been used in the past. So there was passive drowning, active drowning, drowning in salt water versus fresh water. There was secondary drowning, or the symptoms that came on 24 hours later. All of these are no longer being used. And what we want to do now is we want to use either submersion or immersion, and just using drowning as, did someone, so 2 different types of injuries. Immersion injuries being you're in the water, the pathophys is mostly environmental, hypothermia, or complete submersion. Did your airways go under the water? And both of these, the real concern here is just lung injury from being in the water as well. So drowning is that condition where the lungs have gone under the water and there's damage to lungs from that. So just the underlying pathology, it's in the environmental, which is often just the hypothermia or the low oxygen state. So going down the guidelines, we're going to go step by step. So what could go wrong? So these are just a couple pictures of water rescues. And the point here is that a lot of rescuers are still dying by going out and trying to save people in the water. Just wanted to bring that back to life, say, hey, you shouldn't be going in the water unless you're trained appropriately. And we can go back to our old adages reach, throw, row, don't go. Same thing it's always been. You know, if you can get to someone by reaching, great. If you need to throw something, row a boat. But really, rescuers should not be entering the water unless they're trained properly. And they, you know, put in a lot of statistics on just rescuer deaths around the world. So moving forward. So this was kind of cool. So they did talk about in-water rescue. So there were some lifeguards that were taking victims out beyond the waves. And the issue here was that if you were going to go out and try to save someone and then drag them to shore, having a delay trying to get back to shore, trying to struggle through the water, that would prolong the time until someone had any treatment for their hypoxia or their lack of ventilation. So these lifeguards were bringing people out beyond the waves, then they're using helicopter to pick up these patients. But in the meantime, they were providing rescue breaths while they're in the water, and they had increased survival. So that's an interesting model. If you have the right training, resources, providers to do something like that, that's generally what the recommendation was, that you should consider getting some sort of intervention to the patient as quickly as possible. And so if that means, you know, getting them somewhere in the water still and providing those rescue breaths, that's going to be preferred to a delayed extrication time before giving them anything. So car submersion. So there's a lot of misinformation out there about when do you get out of the car. A lot of people believing, oh, do I sit in the car and let it sink to the bottom? Do I break out the glass? Do I kick out the glass? You know, we see this on TV a lot. So a lot of misinformation. And what they settled on was, you know, this simple recommendation: get out of the car as fast as you can. So seatbelts off, windows open, out immediately, children first. So get your kids out. And SWAC was the acronym for that. So just a general safety idea. So hypothermia. The first recommendation they had talking about initial resuscitation of the drowning victim was hypothermia. So, you know, definitely consider it in all of your patients. They didn't go into a lot of detail because they wanted you to look at the WMS guidelines on hypothermia themselves. There's a little bit more discussion about that later on in the recommendations, so I'll come back around to hypothermia, but definitely think about it, treat your patients appropriately for hypothermia. All right, so in terms of other initial resuscitation, we're going back to the ABCs. This is mostly an issue of hypoxia, airway injury, and so we want to make sure that we're focusing on getting patients ventilation and oxygenation. So amongst the things that they wanted us to do is, you know, if you are teaching people to do CPR in this situation, hands only is probably not the way to go. So you want to make sure that if you are training people that are going to be in this setting, you know, if it's teachers monitoring a swimming session or backcountry outing, make sure that they are trained in rescue breathing and that ventilations is going to be something that we get to first. And then, of course, you know, the old 6 to 8, this is just, you know, how often do we give a breath once we've added a advanced airway? So, you know, get that airway quick, get those ventilations in quick. The next couple of recommendations that they have were all based around don't delay respirate or ventilation to do other things. So they want high oxygen. So even though there's been a lot of talk about, you know, giving too much oxygen and causing injury to the lungs from the hyperoxia. In this setting, they found some evidence that showed, you know, even they had a physiological study that showed that during CPR, even with the high oxygen, we weren't getting the physiological hyperoxia that we're concerned about. And so in the setting of drowning, where our main concern is the hypoxia, there might be some pulmonary edema or some other injury, totally safe to use maximum oxygen delivery, at least during the initial phase. Not super concerned about the secondary injury from the high oxygen. So something that would delay getting someone oxygen ventilation was the Heimlich maneuver, something people talked about way back when. Well, not way back when, but it was suggested for a while. The evidence was not conclusive on it. So the recommendation is just, you know, you don't need to do a Heimlich. Some of the old suggestions also were, rolling someone over a barrel, some of the old suggestions from Dublin, or, taking some smoke and blowing it up where the sun doesn't shine. So the Heimlich maneuver is going into that old category of things that we don't do anymore. And really the recommendation was based on give them ventilations that's oxygen as quickly as possible. They mentioned some supraglottic devices. I thought it was interesting that they mentioned them. They said, if you're not getting good chest rise with supraglottic, take it out. Okay, fair. And then go back to, bag valve mask. But some of the discussion was about who can do supraglottic devices. Lifeguards could do them in mannequin models. Could they do them in real life situation? Was unclear. If you can't use a supraglottic device, you probably are not going to be using a bag valve mask very effectively either, would be my concern. Just you can use one, use whatever you're comfortable with, make sure that you're giving a sufficient oxygenation ventilation, make sure that you're giving bag valve mask ventilations till you have chest rise. So this is more for our pre-hospital providers and deciding what we want to work with them in terms of what tools they have. All right, so AED. So again, we don't want to delay ventilation and oxygenation in our patients for an AED. We're going back to the ABCs, but you want to think about the exact situation. So if we have a patient who did go into an arrhythmia and that's why they drowned, okay, we want to grab that AED first. Otherwise, the prevalence of VFib arrest was super low, like 10% in drowning victims because of the pathology with the progressive hypoxia, myocardial injury. We actually see more of a progression from tachycardia to bradycardia and asystole, PEA and asystole, not as much of the VFib, VTAC arrests. So unless you're thinking about another cause of this person going down, it's not the main priority in most drowning victims. So grab it if you have it, use it, but don't delay ventilation oxygenation. So spinal immobilization. So this is a lot of people doing, some silly stuff in the water. So, the old thing was, if you had a patient that drowned, just you do spinal immobilization. Unless you have a good indication, so a high risk mechanism, this was, someone that was diving, someone that's altered or, has symptoms, has actual focal neurological deficits, not really having to prioritize the spinal immobilization as much as you want to prioritize ventilation and oxygenation. So it's going to be clinical context, but we don't need to blindly use spinal mobilization on every unconscious person we find in the water. You have to think about the context and whether or not it's actually a risk. And that was based on just a very low prevalence of actual spinal injuries in this in the population. And even I think it was 0.5 to 5% in the population of divers. So even with the high risk mechanism, spinal injury was very low, not worth delaying other treatments. So what do we do after we do our initial stabilization? So here's my ARDS-net. So for ventilator management, we're doing our ARDS protocols, tidal volume 6 to 8 ml per kg. We're targeting our P plateau to less than 30 by titrating our tidal volume and our rest rate. And then we're trying to target our PaO2 to between 55 and 80. And we're using our FiO2 and PEEP to do that. So last recommendation, use the ARDS-net. There's probably some overlap between the drowning pathology and ARDS. So that's where that recommendation came out of. Positive pressure. So can you use positive pressure? Certainly. Is there going to be some benefit? Do these patients have some pulmonary edema? Sure, totally. So, whether it's, non-invasive positive pressure or you're putting them on the ventilator, but in the setting of, using CPAP, BiPAP in the field, there was at least one study that showed that there was no decrease in survival or similar survival between using the non-invasive positive pressure and endotracheal intubation. However, we know that ET tubes delay time in the hospital, so longer hospital stays, longer ICU stays, more chances of pneumonia, so higher risk of complications. So if you are trying to go between the two, think about the risk factors. Positive pressure, non-invasive is definitely the way to go nowadays. And then, just thinking about our contraindications, right? If someone's vomiting, we're not doing positive pressure, or it should clarify, we're not doing non-invasive positive pressure. And if they're altered, obviously we can't do that as well. But does positive pressure have an impact? Possibly. Imaging. So imaging labs, there was very low correlation between our getting a chest x-ray or doing initial labs and what happened later on. So the studies they found, they showed that if you did an initial chest x-ray, it really had no correlation. If you did an initial head CT, if it was bad, it had predictor for bad outcome, but if it was normal, really couldn't tell you anything, especially in your awake, minimally symptomatic patient. The chest x-ray, again, no real correlation early on, but later on, if they're starting to develop symptoms, totally reasonable to get that chest x-ray, monitor for the pneumonia. But be aware that with the pathophysiology, we're also going to have a hard time differentiating just between a pneumonitis. We'll get to that in a moment when we're talking about antibiotics. But you don't need an initial chest x-ray. You don't need initial CT of the head. You don't need initial labs unless you are considering other causes of them being down. So if you are thinking, tox or metabolic derangement from something else, certainly go ahead and get those labs. The other big thing with the labs was that there's certainly been thought in the past that if you swallow a bunch of salt water, you're going to cause some sort of changes in physiology, electrolyte disturbances, and that just wasn't the case. They did some dog studies. They looked at how much that was compared to humans and how much humans are swallowing, and the volume just wasn't there. So we're really not concerned about metabolic derangement in these drowning victims unless that was what caused them to drown in the first place. If they have underlying seizure disorder, things like that. So labs are really just to chase other causes rather than actually looking at the drowning itself. Let's see. All right. So ABGs as well. Certainly you're welcome to get ABGs just to track and trend. But there was no recommendation of you need to get an ABG. All right, so head CTs, just mentioned that. If it was bad, it was bad. It had some predictors of bad outcome, but definitely not a reason to get an early CT. You don't need to get them on your stable patients that are in the ER. Let's see. So antibiotics. So do we need to treat this patient who swallowed a bunch of water and probably has like this pneumonia from some weird bugs in the water? And the answer is no. We don't need to just throw empiric antibiotics at the patient. So the reason we don't do empiric antibiotics is because the bugs that actually will cause the pneumonia from drowning in these patients, they're not covered by empiric antibiotics. So the recommendation is, get your cultures early, get your sputum, get your aspirate, and when that comes back positive, treat that bug. Or your urine antigen testing, but all these bugs are atypical. So you don't need to do empirics. If you give empirics, it's not going to treat the bugs you want to treat. So wait until you actually have something to treat and then treat that. Early on, we're going to have that clinical picture where you're hemming and hawing about, is this a pneumonitis versus pneumonia? They're going to look like a pneumonitis. They're going to have the white count. So just think about that early picture from the injury. And you don't necessarily need to jump and go at antibiotics. All right, steroids. So this was a historical thing. Is this going to help out? Is this going to improve pulmonary recovery? Is this going to improve or increase surfactant? No, there's no evidence that says it will. So this is one of those things on the back burner. There's not really any evidence that says it is. It shouldn't be a routine administration kind of thing. But does it help? I don't know. There's not enough evidence. All right. So this is Wim Hof. So he's doing some therapeutic hypothermia. So do our patients after they've drowned get therapeutic hypothermia? So there's a couple things here. One of the major things that can happen with our immersion injuries is they do get cold and they might be hypothermic. But in our ROS patients, so the evidence that they looked at showed, well, the evidence that exists for the therapeutic hypothermia was in VFib patients. What they did was they cooled them to 32 to 34 degrees for the first 24 hours and had some improvements. In other ROS patients, there wasn't any evidence. So hospitals that are using therapeutic hypothermia on your non-VFib ROS patients, is there evidence for that? We don't know. So if you have a patient who's in ROS after drowning, do you do therapeutic hypothermia? We don't really know. It's really an extrapolation kind of situation. Up to you to consider. Again, it's a 2C recommendation from them, but it's going to be following those ROS protocols rather than any evidence that's specifically related to drowning. There isn't. If you do have that cold patient that you're rewarming, do you stop rewarming when you hit that target range? Was another question. Is there an answer to that? Not really, but it's something to consider, and maybe we'll have evidence at some point that says that that's also helpful for those patients. All right, so we're moving right along. So we've moved through our resus and we've moved to post-resus to disposition in the wilderness. So when do you evacuate? When do you get the dog out? So there are a couple things that they showed, and there was a huge body of evidence from some lifeguards. They had 42,000 cases where they were able to pull some evidence, look at initial symptoms, progression of symptoms. And what they really found was that in patients without symptoms, there was really good survival. The patients that they were worried about, and I should have thrown on the chart here, but when you started to worry was when you had actual changes in the lung sounds, if you actually had rales. So if you had a patient with mild symptoms, which being a slight cough, really the chance of death was pretty minimal. But when you added on abnormal lung sounds, that chance of death started to rise, 0.6. You add on some actual acute pulmonary edema, and now you've got 5% mortality. And then going from there, if the patient was hypotensive, so if if they had a low MAP, or if their blood pressure is, if their systolic was below 90, or if their MAP was below 60, those patients started to have a worse and worse outcome. That's where we got the evidence for when to actually evacuate patients. And the idea is if you have a patient who is asymptomatic, you definitely are not super worried. But then it's the patients that might have some mild symptoms where you want to start considering evacuation. And then certainly if you have worse symptoms, you want to begin evacuating. But then you want to weigh the risks and benefits of evacuation. So where are you? What's going on? What are the risks to the actual rescuers and getting that patient out? If you begin evacuation and your patient has improved and has no symptoms for 4 to 6 hours, the recommendation is you can probably stop evacuating that person. If that patient is normalized, you don't necessarily need to get that person out. If they're getting worse, you should start thinking about getting them out quicker. Let's see. All right. So when to cease resuscitation. So this was controversial. So, I think that we've all heard about these kids that have been submerged for hours in super cold water, and then they come back. They don't really have horrible neurological outcomes, and that's amazing. These recommendations didn't really look at those abnormalities or those kids that, survived that. More what they were looking at was your average drowning patient. And so they gave recommendations on how long do we resuscitate. And this was based on evidence on after arrival of EMS. So 30 minutes if it's warm water. And then if it's cold water, less than 6 in or less than 43 degrees Fahrenheit, it's reasonable to consider resuscitation for 90 minutes. But realizing that outcomes, significantly decrease, after, if you have someone who's been submerged for less than 10 minutes, your outcomes are definitely going down. After 25 minutes, there was really not good outcomes at all. I think that's pretty similar to just our general CPR outcomes. And then they point to one study specifically, which was in kids. So some people that we would be a little bit more hopeful for survival, and they had 98 kids receive CPR after drowning for more than 30 minutes. They had 11 kids survive after 30 minutes, but none of them had good neurological outcomes. So just something to think about. They all were neurologically devastated despite that prolonged resuscitation. All right. So these are our risk factors for drowning, our prevention. So I don't want to skip over emergency department watching. So we had some evidence earlier, so I'm just gonna stay on the slide for a minute. When they had evidence before about symptomology and how long it would take for someone to develop symptoms. So they had some evidence that showed in patients that developed symptoms after drowning, those symptoms typically came on within the first 4 hours. There was a study that had one outlier that came on at 7 hours. These were kids. And in that patient that had symptoms develop at 7 hours, they had a good outcome. So in terms of how long do you need to watch someone who doesn't have bad symptoms while they're in the emergency department, the recommendation is 4 to 6 hours. They looked at a bunch of evidence from past years, and then even the past few years there's been more evidence. And there was one article that came out, and they actually gave some guidelines, which was, how do you discharge someone who's been in the ER for 8 hours? And the 4 things that they showed were reasons that if they met all these criteria, it was safe to discharge. And that was having a normal mental status, having a normal respirate, not being dyspneic, not needing airway support, and not being hypotensive. So that's kind of a combined thing from some of the previous evidence that that last trial looked at. So if you're watching someone in the ER and they're asymptomatic, 4 to 6 hours. If they develop symptoms, definitely longer. If they need that initial resuscitation, if they're hypotensive, if they need interventions, definitely you're thinking about watching a little bit longer. So how do we prevent drowning? People we need to watch out for. Autistic, epileptic, long QT, and coronary artery syndrome. So these are all people that were considered at higher risk for drowning or causing drowning. So if you are on the prevention side of things, if you're doing screening for participants, these are the people that you want to have some recommendations about, buddy swimming, swimming with flotation devices, things like that. Especially in epilepsy, they should never be swimming alone. And so that was the strongest recommendation of, if you have a patient who does have epilepsy, they need to be monitored at all time while they're swimming. And the other patients were more relative contraindications. All right. So emergency, that was the slide I was supposed to talk about, the 4 to 6 hours, but we already did. All right. So swim testing. So something we do for participants in various activities, backcountry outings. If you actually take someone and you give them a swim test, is that reasonable to say that they're going to do well? So the idea was, if we have our participants routinely swim, I think it was 25 meters, is that enough? If people have swim literacy or the ability to actually swim, is that going to say that they're going to be safe? And the evidence was kind of hemming and hawing. Most likely, yes. Common sense says yes. So we should probably continue with those measures in screening our participants. The other question that they posed while looking at the research and evidence there was, do we teach kids to swim early? Do we teach kids just how to do survival swimming? And there was just a discussion about it. Do we worry that if we teach kids to swim too early, or parents go to swim classes, that they then are less vigilant and don't watch their kids as well, was a concern. And this was really just a discussion. There was no consensus really on, is it good to have swim lessons or not? Well, that was how I read the paper, but we have a couple authors here, so please correct me if I say anything that's poor. All right, flotation devices, PFDs. So they looked at a couple things. So in boating accidents, there were a number of deaths. Deaths were higher in people that weren't wearing PFDs. Is that just a association? I don't know. They looked at a study that showed after they imposed stricter regulations and to enforce using PFDs, that rates of death decreased in those areas. Is that just causable? Is it or is it just an informal relationship saying in places that are stricter and are monitoring things and are making sure that people are being safe, that people have fewer deaths? I don't know. Especially because people that were wearing PFDs didn't die as much. So I think that common sense. Why not wear PFDs? There's no reason to say no to that. And if anything, the evidence points towards PFDs saving lives. All right, don't drink and swim. So alcohol was associated with a lot of drowning incidents. I think this is commonly known. It's associated with a lot of boating incidents as well. Alcohol in general is just going to impair people's judgment, make people do less smart things. So general recommendation, don't let your participants drink and swim. All right, so just some other prevention things, planning and lifeguards. Is there, so they looked at a study that showed that places with lifeguards had fewer deaths at those beaches. So great. I guess lifeguards save lives. Certainly the lifeguard associations will say that they do. I'm going to leave it there. I think I'm getting into my own opinion. But I think that, why not have lifeguards? Why not have training and planning? So if you are planning to have events and run situations that have a water sports, certainly you need to have contingency plannings. You need to prepare and have appropriately trained providers. And if you're going to have high risk events, whitewater sports, things like that, it's definitely appropriate to have people that are trained in swift water rescue and higher levels of care and actually getting into the water and rescuing these people. So they had just added that as a general recommendation. Yes, lifeguards probably do save lives. And yes, we should be planning and prepping and making sure that there are people that are trained and appropriate when we have these major events. All right. So cold water safety. So this is more about survival for yourself. So if you fall into cold water, what are the recommendations? And in general, you fall into cold water, things that will help you survive are wearing that PFD, wearing insulating clothing, having other preventative measures that way. But then you need to make your decision early. You're going to have, your muscles are going to get cold. There's going to be decreased motor function. There's going to be decreased mental function. So safety first. If you're going to swim to safety, the recommendation is to go to safety as soon as possible before you tire out, before your muscles get cold. If you aren't going to swim to safety, the idea is get on top of something, get your body out of the water as best you can. And one of the recommendations was take your clothes and stick them to something. So, you got the cold tongue here, the wet tongue sticking onto something. And that was just an idea that if you are going to progress to decrease mental status, make sure that you're tied onto something and tied above water if you can. And, literally just take your frozen clothes and freeze them to the ice. And then the help position, something that has been around for a little while. Just a recommendation for heat loss. Keep your arms at your sides, keep your legs together. If you want to go further, tuck your knees to your chest. And the whole idea is that, we're going to lose the most heat from our axilla or groin. So protect those areas. If you've got a group of people, the recommendation is to huddle. And that should help preserve heat loss as well. There was a concern, though, that if you do have a group of people huddling, it does improve morale. It also allows you to keep weaker people afloat, or injured people afloat, but you might actually have more heat loss by trying to help everybody else stay afloat. So there is that. But in general, if you have a group of people, it's probably better to stay together and stay in a cluster. And that's bringing us to the end of the slides. So I know that we have some of the authors on here, so I'm hoping that they are going to correct all of the things that I said that were wrong. Yeah, any questions?
This is Schmidt. Thanks. That was awesome. I just finished the sedation I was doing before. I don't have any questions or comments for you. I think you did a great job. I know Seth and Justin Simpsprott are both on as well, so they're usually more verbose than I am. But I hope some participants out there have questions. So I'll just kind of sit on the side in case anyone has a question.
I wanted to mention that one time there was a little girl at the swimming pool that my mom actually ended up saving. She was blue, and the lifeguard wasn't really sure what to do, I guess. And my mom ended up like sucking the vomit out of her nose, and then that kind of opened her airways.
Yeah. So one thing, I mean, like you discussed in the main, I mean, everything's about takeaways and what you take away from this. And big takeaways, mainly for me, is how can you get oxygen in this patient? And what we do know about drowning patients, especially severe drowning patients, is that majority of them will have some sort of vomitous material or foamaceous material. When surfactant and water mix, you get kind of a foamy material, and so that can obstruct the airways. So if that seems to be obstructing the airway in some means or some way, then anything you can do to relieve that obstruction is going to be the right thing to do. There's some controversy right now. There's a device out there, a proprietary device that's made for choking kids that is kind of being advertised for drowning. We don't have any data if it actually works. There is concern by focusing on the airway obstruction that you're actually not going to be giving oxygen, because if you spend a minute or so trying to relieve the obstruction, you might look over the fact that you need to give oxygen. So you need to remember that. But if you do believe that there is an obstruction that is actively obstructing flow of oxygen to the patient's airway, then basic maneuvers to relieve that obstruction are great, as long as your goal is then to return to trying to give positive pressure ventilations.
Excellent. Yeah, she saw the vomit in the nostril, and then she gave breaths. Thank you.
Hey guys, this is Justin, coming to you from a hotel room in Elko, Nevada, on my way to start a shift here in a couple of minutes. But getting back to that concept of airway management, it used to be way back when the focus was trying to drain the water from the body, and whether it was hanging them upside down, throwing them over a horse, swinging them around, a lot of the focus was to try and drain this fluid that's coming out. And for simplicity, I call it foam, but it's non-cardiogenic pulmonary edema from that small amount of aspirated water mixing with a large surface area of surfactant, and then getting aerated and coming out. And it is frequently misidentified as vomit, when the reality is, even if you're clearing it from the upper airways, you're not clearing it at the alveolar interface. And so it's not necessarily obstructing the airway. And I often joke when I'm training lifeguards that you can spend the rest of that person's life suctioning and trying to clear away that foam at the expense of oxygenation. And as Andrew said, giving the breaths and positive pressure ventilation, even just pushing that foam back down may be the thing to do, because once you get them intubated, you're just going to increase the PEEP anyways, just like you would do with CHF. Or sure, when we intubate somebody in flash pulmonary edema, we do some degree of suctioning, but really the treatment is to increase the PEEP and splint the alveoli open and push that fluid back across. Same with the drowning patient, but those first few minutes are so critical right after they are pulled out of the water. And then the only other comment I had, again, thank you for the great presentation, and it's always fun to see our work grow legs. Andrew and I actually grew up lifeguarding together back in the 90s and early 2000s before going to medical school, and for years felt like we were the ones kind of screaming from the mountaintops. And it's fun to see kind of our work grow legs of its own. But absolutely teach all kids to swim at whatever age is developmentally appropriate for them. The AAP used to recommend against swim lessons under age 4, then they changed it and said we're no longer against it. We're not for or against it for age 1 to 4. It's an individual decision, and that's something that we advocate for.
Any other tips from everybody involved in writing the guidelines, or any questions for them before we move on?
No, like I said, two main takeaways for me, and what I try to hammer in anytime lecturing this is just hypoxia, hypoxia, hypoxia. It's what causes morbidity, mortality. It needs to be your focus of treatment. You'll have on these are crazy scenes of 20 different people with 20 different certifications coming on scene, and you may be the only one that understands that. So when other people come on and want to do something else that's going to take that focus away, be it C-spine mobilization, be it suctioning if it's not necessary, being a Heimlich, being stuff like that, they're the ones that need to go call 911 and you take care of the situation. Other thing is, and I know this is Seth's ball game, he's all about what words and what they mean, and I agree with, especially in drowning. You folks will be the front line of information and misinformation. And there's a lot of misinformation that we talked about in the practice guidelines, but just understanding basically what drowning is and using the right nomenclature, it's going to help us collect the right data and provide the right treatment. Just make sure we're all speaking the same language. So if you take anything away from it, that's it. And lastly, Justin and Seth will agree that we 100% love hearing from people. And if there's ever a question, or you think you are trying to answer a question you aren't able to answer, you just contact us. This is our passion, and we'll be happy to help you.
And then I'm going to drop 2 links in the chat. One to an 1.5-hour presentation on the pre-hospital treatment of drowning, if you want to check it out. But it has numerous videos of this foam and of this kind of flash pulmonary edema that we see, or this kind of looks like flash pulmonary edema, but it's obviously non-cardiogenic in drowning patients as well. It's an 1.5 hours broken down into 7 segments, optimized for offline viewing on iPads and phones if you want to check it out on the treadmill. And then also the presentation should have, I'll put a link to the shorter version that was done at the Wilderness Medical Society meeting last year as well.
One quick thing I'd add for the wilderness setting that's really striking about the information in this particular clinical topic is the 30-minute line to move to body recovery. And there's not that many things that have to happen so quickly in pre-hospital medicine. So the point, that you made, Riley, which is really good, that the data suggests that clock starts when EMS arrives is not a very helpful line for us, in a wilderness setting. So I think it's important to recognize, particularly from Sarah's story, that, the people that are doing these interventions that Justin and Andrew are talking about are mothers, camp counselors, people on trips. Sometimes there's no known patient and it's a submerged story, and that 30 minutes is really short. So this is sort of a prototypical condition where most of the action happens in the first couple minutes for whether the patient's going to have a good outcome or survive. So it's really great for us as a topic to push home, in wilderness medicine training and for us to be very much on top of, because that 30-minute window is when a lot of the core interventions are going to happen or not.
All right, well, thanks everybody. I think one thing interesting as a student, as a resident, is you will see your fellow students, your co-residents, your attendings, consults refer to it as secondary drowning, dry drowning all the time. I know there was a lecture given by I think it was either a pediatric ICU attending or pediatric hospitals attending, talking about the hazards and the dangers of secondary and dry drowning. And they don't really care what you think when you're a resident or a student. So just remember that, like, as the experts in this field, like, this is, we're hearing from the people that like wrote this, and we know this. So do your best to educate when you can, and remember that the world is changing, I suppose, in the nomenclature, and we're ahead of the curve. Just kind of keep that in mind. But we are going to move on to to the cold immersion article next. If anybody wants, after that, we could move on to the flush drowning article. We talked about that on our fellowship trip, and it's a couple of the authors are here, and it's kind of a fun thing to talk about because they are the experts who wrote this, and they are definitely more strongly opinionated on it than I would say I am too. So are you ready for, there she goes.
There we go. Can you guys see my screen? Oh, awesome. Well, it's awesome to meet you guys. I'm brand new here. I'm a baby med student, not because of my age, I'm older than most students, but in my knowledge. So I appreciate any contextualization you can bring to this, any physiology. I will not be offended if you interrupt me to correct something or provide context. So I'll just start with that. I'm a first year student at Virginia Tech. I'm a whitewater kayak, thanks to my partner, Danny, who is here. I've roped in for any questions about paddling, although I'm sure there's some paddlers here in the meeting. We've done a bunch of boating in the Southeast mostly. They've done boating out West. And I know that's one of the concepts of flush drowning in the article we may discuss later, is about sort of regional differences in the water. So we're excited to dig into that. This is a review article about flush drowning and any associations with cold water immersion, maybe as an explanatory factor in it. So this was published last September, or the summer before last September, really just looking at cold water immersion syndrome as a potential explanatory factor for what we colloquially refer to as flush drowning. So why is this important? So American Whitewater, which I have a link to here, is where we sort of go to look for quality and information about a river's runnability, any accidents, et cetera. They also do accident reports anytime there's a whitewater death. And if you look at those among sort of, in particular, like rafting or kayaking deaths, a lot of them, 20%, are categorized as flush drowning. And for something that medically speaking, we don't really know how to kind of explain this. Is there really a difference between flush drowning and other kind of drowning? I think this author is really trying to get at, what does this mean physiologically? Is this something different than an immersive drowning experience? So for background, the study by the same association in the 90s suggested that there were kind of major causes of death and drowning deaths specifically among those in watercraft. So entrapment in strainers and sieves, flood conditions generally, exposure to hydraulics, and then sort of secondary causes associated with equipment not having a PFD or cold water, hypothermia, et cetera. And so I just wanted to offer, just as background, what these things are. I didn't know what these were until I started kayaking. So strainers are kind of what you see here. If you see, potentially you'll have actual trees in the water. This is a river some of our friends run in Chioa, Western North Carolina. It doesn't run that often. It's only with high water or when there's a dam release 3 times a year. So the trees can actually grow. So yeah, I see Chris, have you paddled Chioa? Mad respect for you if you have. I'm way too scared of all the trees in this river. The idea with strainers is that you get caught up against whether it's an actual tree or if there's sort of log jams in the river, the water's pushing against your boat, and it doesn't take much pressure, much speed in the water to really be unable to get away. You get really pinned against a tree. The water's going through, you can't. So water builds up. I've got links to videos. I can share the slides if you want to see what this looks like in real life. That's a little bit different than what we see with entrapment in sieves or undercut rocks. On the left here, you see an undercut rock. The idea is that if underwater, there's sort of a V shape in the rock there, as the water can kind of take you into that V-shaped kind of underwater area, and then it's really hard to get out. And this here is a river in West Virginia. The rivers here are very rocky. They call them creaky, which I think doesn't really speak to the tenacity of the rivers here, but the idea is that there's a ton of rocks. This meadow river at higher water, all this stuff is underwater, and where this guy is sitting in this cave, you could end up with a boat and a person in the boat kind of being sucked under there. It's much more dangerous if you're out of your boat than if you stay in your boat and stay afloat. Hydraulics, on the other hand, a little bit different. This happens with low-head dams in particular. There are some occasional natural rivers that feature this. The idea is that it's a smooth line and it creates this sort of perfect recirculation at the backwash here, and people just get stuck in it. And again, there's a link to a video if you want to see this kind of happening in real time, what that can look like.
All the videos have happy endings.
They all have happy endings. Yeah, no one dies. So this is a forewarning. Flush drowning, on the other hand, we use this for an event where it's non-traumatic. You don't have someone getting hit in the head with something. There's not an entrapment in a feature. Exhaustion and aspiration are associated with it. Usually a kind of big water, a long swim, where you're just getting a face full of water over and over again. They're associated again with high water and colder temperatures. You tend to see this kind of water out west, but you definitely have this occur sometimes in the southeast rivers. Really anytime someone is perhaps being rescued and has to deal with a face full of water for many minutes, you can kind of see this happen. But like I said, this is a colloquial term. There's not really a medical explanation per se. And as a result, we use this terminology, and then you can end up with this being misrepresented as cause of death on death certificates. So for someone like me as an epidemiologist and trying to analyze those death certificates and say, okay, which of these are drownings, you can often have death certificates that would record something like heart disease or a heart attack in MI as being a causative factor. This is a great video of what it looks like. I don't know if we have time to watch a video or not, but maybe at the end, if we have time, we could watch it. It's world-class kayakers saving each other from this potential flush drowning event up in the Pacific Northwest on Class 5 water. And I think it just really illustrates what it looks like. So the idea with this review was the idea that this perhaps some flush drowning events, and maybe the majority of flush drowning events, particularly those in cold water, could really be a manifestation of cold water immersion syndrome. So they kind of go through reasoning to explain why perhaps this is a different phenomenon. It's really this cold water impact that's causing this type of drowning. So they kind of will go into the physiological explanations for that. So starting off, they have cold water physiology. The idea is that we're seeing drownings even among really strong swimmers in cold water, where it's not necessarily hypothermic, but there's an incapacitation of some sort. So this sort of happens, this cold water physiology can really occur at quite warm temperatures. This surprised me. It's 20 to 25 degrees Celsius, so 68 to 77 degrees Fahrenheit. So anything below that, you can kind of start to see a difference in our physiology. It's broken into 4 discrete stages of cold shock, swimming failure, hypothermia, and circumrescue collapse. The first 2 here are quite important with regards to flush drownings. The last 2 there kind of start to take effect 30 minutes or more down the road. So typically people have been rescued by that point. But it's noteworthy that when these stages were created, it was in the 80s or 90s. And so we didn't really have description of some of the cellular transcription, cold shock proteins, initiation of shivering thermogenesis, and increased metabolism that could be playing a role. And just as a note, again, with the water temperatures, I was thinking about this. I don't really think of cold water immersion as occurring in the summertime in the southeast rivers that are not fed by the bottom of a dam or river. Kauai is a great example. There's a great big tourism industry around rafting in the summertime here. You can go there and wear a bikini and a PFD and go down the river on a raft. But technically speaking, the water is cool enough that you could theoretically have this physiological change even in the summertime in the Kauai River. So I thought that was notable and relevant for the second paper if we address it. So So first step in physiology, we're talking about the cold shock. This is the first stage. We have a group of reflexes that occur within 5 minutes of exposure to cold water. It's triggered by thermoreceptors, especially in our extremities, and it causes this involuntary gasp that I think someone mentioned in the chat earlier. This is accompanied by tachypnea and peripheral vasoconstriction, and it actually kind of ends, it's terminated by sort of reflex baroreceptor response and even a temperature habituation. The author notes in the paper that the combination of poor breath holding ability and tachypnea together during this phase enhances the likelihood of just aspiration, especially in turbulent rivers where a swimmer kind of really has to be synchronizing their breathing with when they're kind of up on the crest of the wave versus kind of down in the valley of it. The next step, stage 2, this occurs within 30 minutes usually of exposure to cold water, is a swimming failure. So you're seeing cooling of the extremities, a hyperventilation induced tetany, and shivering thermogenesis. All these things combined can make it really hard to use your limbs to swim to safety. You don't have that coordination or an inability to self-rescue. And anyone who's in kind of paddling sports knows that self-rescue is super important for being able to survive a potential drowning scenario. Self-rescue is incredibly important. So the fact that this could occur, within 30 minutes could perhaps explain why we have really experienced boaters and really experienced swimmers potentially suffering this fate where they appear to be unconscious or just unable to swim. Something I thought that was really interesting, and again, I'm a total noob to medical physiology, so this may not be surprising to you guys, the idea that as tissue cools, nerve conduction diminishes, and this process is accelerated by muscle movement in a struggling swimmer. So the idea that perhaps by moving around more, we could have this perhaps set in sooner. It was really, really interesting. The next stage is hypothermia. As you all, I'm sure, know, this is when the core temp is below 35 degrees Celsius. You see this happen when someone's immersed in water at 5 degrees Celsius for about 30 minutes. You'll see ataxia, shivering, dysarthria, apathy, and amnesia. The paper notes that for flush drowning in particular, victims are often recovered on a time scale, which makes hypothermia an unlikely contributor to death. So again, typically, even on a fast river, ideally they're rescued by their boating mates within 30 minutes. So it's not likely that this is a really great explanatory factor for why folks are experiencing flush drowning deaths. Next, we have the circumrescue collapse. So there's a number of factors here. We see cold diuresis, stress hormone reduction, core after drop, everything is kind of giving up. You end up with hypovolemia and arrhythmias. You can end up with people passing out or going to cardiac failure at this point. It really requires really prolonged submersion in cold water. So again, like hypothermia, probably pretty unlikely to explain the flush drowning deaths. So the paper also goes through a contrast of this cold water immersion syndrome with just mammalian diving reflex. They're a little bit different. So mammalian diving reflex is an adaptive reflex that some mammals have, especially those that go underwater. So bears may be better at than us, where the oxygen is conserved. They're much better at keeping their blood pressure stable and cardiac output low than we are, because we get stressed out and shoot up our catecholamines. That kind of goes against this sort of relaxed state of diving underwater and finding fish. So this response is triggered by thermoreceptors. Something a little different than what we're looking at with cold water immersion syndrome here is that the thermoreceptors are really in the base. You're looking at trigeminal nerves, vagal nerves. You're seeing pulmonary stretch and chemoreceptors and facial mechanoreceptors respond. One thing that's notable is expiratory apnea. That seems to be the sort of on-off switch for this reflex. And this is, again, so after you've breathed out your air, kind of holding your breath, this seems to be really notable in this case. You see peripheral vasoconstriction triggered by hypoxemia or hypercarbia, not pulmonary stretch receptors. And in humans, we see this adrenal catecholamine release and sympathetic activation, which kind of will act counter to this diving reflex. Vascular splenic contraction, And one thing I thought was notable is this reflex is more pronounced in 15% of human adults. So some people are just better at this than others, but it's certainly enhanced by those who exercise often and those who practice, going underwater, getting comfortable with holding your breath for a long time underwater. And I think being able to kind of stay in a parasympathetic state. And the author kind of says it's unlikely to explain flush drowning because we don't have like prolonged apnea. In the cases of flush drowning, folks often have their head above water and access to oxygen. So interesting. The next go into cardiac arrhythmias and this idea of an autonomic conflict. This is more of a hypothetical postulation, but there's potentially a role for cardiac arrhythmias in flush drowning. Cold water induces rhythm disturbances. It's apparently quite common, but often asymptomatic. So folks may not even know they're having arrhythmias when they are in cold water. There's this thought that perhaps there's a role for a sympathetic and parasympathetic coactivation or conflict, which causes ectopic beats and arrhythmias. This apparently can be seen in sort of states of anger, where there's this sort of balance between sympathetic and parasympathetic kind of coming to a head. It's accentuated by a parasympathetic stimulation with facial submersion, cold water, or even breath holding. You can also see hyperventilation-induced coronary vasoconstriction, hypoxemia, cardiac ischemia, maybe from extreme hypertension, heart distension from central blood shunting, and then even a prolonged or shortened QT interval associated with tachycardia or bradycardia. So these are all kind of postulated ideas with, perhaps what's happening here is an arrhythmia that's then leading to death, which could explain why sometimes on these death certificates, we see sort of an arrhythmia or an MI as the reason for death. How do we prevent it? Proper equipment is a great first step. So dry suit, wetsuit, I see some beaters here in their dry suits. There's some friends of mine in North Carolina. Physiologic and psychological conditioning are important. Ability to hold your breath, trying to prevent yourself from shivering, panic reactions, and really having that autonomic balance. Cognitive preparation, maybe envisioning what happens if I end up in a swim and I'm getting just wave train to wave train in my face. Turns out physical adaptation is also possible. So if you have repeated brief exposure to cold water, maybe less likely to have this immersion syndrome, and especially that, that initial breath in that we'd want to prevent perhaps. This can alter your chemoreceptor sensitivity and reduce that adrenal catecholamine release and really enhance your parasympathetic activity, just knowing that this is something you're used to. Controlled breathing can also prevent aspiration. So again, if you know that you've got wave after wave coming, they're coming from different directions, trying not to breathe in until you're at the top crest of a wave can really help in this case. And then trying to delay your shivering, I guess, for as long as possible can give you a longer window where your limbs are working so you can self-rescue. So it seems like there's some ways that paddlers could really be preparing themselves better for this scenario. And I thought in terms of a discussion, I'd really love to know kind of what your experiences are with flush drowning, if you've seen many cases, if you've had an experience yourself. And Chris says we just need to go paddling more and maybe go paddling in cold water. My partner was out when there was snow on the mountains last week, and I just thought I wait till it's warm out. But maybe that's a great way to prevent this. I'd love to know what your thoughts are about whether cold water immersion can really explain most of this, given that we've seen this happen in warmer waters. I'd love to know if anyone has more thoughts about a psychological role. I haven't seen a ton about this, but since we use waterboarding as a form of torture, I feel like there's probably a notable psychological component that maybe we aren't discussing in detail. And then I'm curious to know if clinically, do you think it matters whether drowning was due to entrapment or a flush scenario? Will it change your practice? Will that information impact what you do when you see a patient in the emergency room with this? And here's a photo of us on the mighty Chattahoochee in Atlanta. If you're an Alan Jackson fan, you get the reference. But yeah, I'm excited to discuss this with you all. And again, look forward to hearing what you think based on your experiences.
I could jump in and make some comments here on this if y'all are interested. So a few things here that I mean, first of all, I think it was kind of exciting that someone even just took up the concept of flush drowning, and started just discussing it. And there really hasn't been much discussion of, injuries or illness in whitewater in, years and years in the literature at all. So I'm glad that this is starting to come up, which is great. There's a few things that I think that, certainly the cold water physiology is definitely, I mean, plays a part. To what degree, I think is admittedly no one knows. But I think stepping really back after even reading this article, can anyone really propose what they think flush drowning is, like how they would define it?
I wonder, would it be helpful to see the video for anyone that's not familiar with the idea of flush drowning? I wonder if that would.
Yeah.
I think what Chris is getting at is that there's not, it's kind of indefinable.
Right. Like I think that's part of the thing that's really interesting about it. And if you look at the methods of how they did this study, they went back and actually reclassified things from the American Whitewater database. Essentially, they did define what flush drowning was for this purpose of this study by basically saying it was any death that occurred on the river where someone was out of their boat, not entrapped in something else, and didn't have evidence of trauma like post-mortem, even if it had been attributed to trauma or something like that. If someone hadn't been seen to have convulsions, didn't have observed trauma, or wasn't boating alone. That was another thing too. So any deaths that were done when they were boating by themselves were excluded as well. So really, they've kind of self-defined this thing as it's kind of like what we say in medicine, a wastebasket term of they were in the water and they died and we don't know why. And that, to me, that's the takeaway of that's kind of, I don't know if you can define a pathology of something where the definition of it is that we don't know what happened. So I think it's kind of interesting to think about that, and that we've somehow termed it drowning, yet drowning as how do we define drowning through the last thing is it's a process of respiratory, specifically of respiratory impairment. So it's just, we actually, I think all of the authors, most all of the authors, we wrote a response to this article in Wilderness Environmental Medicine that we'll put in the chat there. I think Justin was going to do it.
Yeah, I sent it. It's in the Google folder. I sent everybody the link to, but I can send a direct link right now.
Yeah, and some of it is a bit of semantics. I mean, but it does matter. But I think that it's difficult because in the whitewater community, it is like everyone knows what flush drowning is. So it's kind of difficult from that sense. But I think we're being a little bit presumptuous to say that we think this is actually even drowning to begin with, when we admit saying that we don't actually have no idea why these people are dying. So
yeah, and I'll kind of add to that too. So the definition of drowning is pertinent for treatment, for epidemiology, for prevention, right? And so the big question for this is very similar to the idea of secondary or delayed drowning, right? These people died after they were out of the water and we don't know what happened, or somebody died that wasn't pinned underwater for long enough to have died. How do we define what has happened? And so terms like secondary, delayed, parking lot drowning, or flush drowning are kind of a search for an answer to that question. And part of that is covered in the definition of drowning because it's submersion or immersion. So you can be in a PFD just getting hit in the face with waves and unable to breathe, unable to time your breathing, aspirate or not, and just be suffocated from that and die by drowning, even though you never went underwater. And the autonomic conflict is, there's a lot of emerging data on that from Professor Tipton and Dr. Patty Morgan out at Portsmouth in the UK. And they have really compelling videos where they kind of dunk healthy volunteers into cold water, and then you see them go into VTAC. They pull them out of the cold water and their VTAC resolves. Most of the time, they're not going into pulseless VTAC, But that could certainly, in somebody who's in their late 40s, early 50s, who may not quite have cardiac disease that's going to cause them to have an acute MI, but that's just enough of a lack of physiologic reserve that VTAC becomes persistent, but then it is resolved, by the time they're dead, and you're doing an autopsy, and you never know why, because they were on there. And so I love the idea of the discussion of flush drowning, not because it in and of itself, I think, is an emerging new definition, but it kind of chips away at those edges of the things we don't quite understand about drowning, which is sometimes people die when they shouldn't, and sometimes people live when they shouldn't. And how do we better define and characterize so that we can prevent and treat?
Mhm.
Yeah.
Yeah, I
So
think
some of
there's-
the things that I think are very interesting and relevant here to think as we speak about cold water immersion and the philosophy and like the physiology of that. However, I don't know how many of you do. I'm a year-round boater. I boat in the winter a ton, and it used to be pretty freezing cold like 15, 20 years ago, but now I've got a dry suit and warm stuff on, and I don't get a cold shock when I go in the water. I'm usually, I mean, I don't get it. So you really physiologically, if you don't have those receptors firing like crazy, you're not going to necessarily experience that. You do have your face exposed though, so it's possible that you could have that diving reflex. But typically, these people have been splashed in the face over and over and over for hours before this happens, and so that's been fairly well blunted. So I'm not sure how significant that really is. I do think there's some other things that were kind of mentioned in their methods and their results that were not really spoken of much. One of the things is that the cohort was like statistically significantly older in the group in the Rocky Mountain group, which is definitely comes into play if you're looking at potential like cardiovascular events and things that may have happened to. They were older. And then also, if you look at the rate of this term being used was like substantially higher in that group as well than it was in the Southeast. And there was a lot of people definitively drowned in the Southeastern group, but kind of as you're talking about there before, one of the consequences is the characteristics of rivers that people are paddling on are very different in the Southeast than they are in the Rocky Mountains. So does anybody like that has been on rivers in the Southeast versus the Rocky Mountain region, like what are some, you notice any like differences the way that the river like trip goes or anything?
Yeah, I think the biggest difference is in the Southeast, you just have more rocks and more obstructions in general, right? Like you have more trees, you have more rocks. Things are narrower typically out here, so it's easier to get to shore in the east than it is out west. Whereas out west, things are deep, and so I think we were talking. She was asking me questions about this, like the Nantahala, which is an incredibly popular river in North Carolina. It's about 4 hours away from Roanoke, and the reason that flush drownings don't happen a lot in the Nantahala is because you were only ever maybe 20 yards from 2 feet of water, right? At any given moment, you can get somewhere where you can stand up. Whereas out west, you could go the entire run and it is never shallow enough for you to stand up. And so you keep getting pounded by that water and keep getting dunked essentially over and over again. And so I think those are probably the two biggest differences, is that the rivers out there are bigger and deeper. And I read the article and I'm not convinced that temperature difference between the Southeast and the West are very different. Lauren was saying that the cold water immersion syndrome can happen in water that's 77 degrees. That's like when we're in the Ocoee in the summer and it's 7, we're like, oh, this water is so hot. And yet your body can still go into that syndrome. So my guess, my uneducated hypothesis is that it actually is more about the character of the rivers than necessarily the temperature.
Yeah. And so one of the other things too, is that if this depth and thing, it's the characteristics of these rapids, and typically, these geologically very old rivers, they're smooth polished rocks. We have the undercuts, which don't really exist so much out there. And then there's also, these because of these old rivers, they kind of drop over some rocks and then they drop into a pool. and they drop over some rocks and they drop into a flat spot, you know, there's very little chance to end up swimming for, you know, even more than a couple of minutes. Whereas if particularly at high water, you know, like high water Middle Fork salmon or something, or South Fork salmon you've been on, and you could get in the water, you know, you take a swim and swim for, you know, 5-10 minutes of continuous whitewater, which is just not the way our rivers, you know, are geologically work in the Southeast. So it's very interesting. There's a lot of other factors. I think there's just, this is like ripe for more investigation, and people want to start looking into an area of wilderness medicine that is really not well researched. This is it. I mean, so that's what I do. So, but it's there's a lot of unanswered questions surrounding this.
It's fascinating for somebody to take up kind of the psychological input, because my experiences with flush drowning are people that are not comfortable in the water, and I would be really interested to see a study that looks at experience and comfort level in the water as a factor. I know that's more, you know, loosey-goosey than medicine is typically comfortable looking at, but I think I would be really curious to see if there was something there.
Yeah, this author, Farstad, so I didn't kind of go into detail in this article, I was focused on the review, but if you read it, it's not, I think, from my perspective as an epidemiologist, that just the way it was done methodologically wasn't very sound. There's like one bar graph with some counts of deaths in there. And I think there's just so much more, even with the same data set from American Whitewater, that we could do to tease out more about the quality of the water, the experience level of the boater, and to try to get some details of what's really happening. But yeah, I think the coldness of the water for sure, and kind of that component.
Yeah, usually.
So with that plug as the kind of always the call for more, Andrew and I also helped co-found the International Drowning Researchers Alliance, or IDRA, and it's free if you go to idra.world. If you're interested in joining, you can submit, and then we have numerous folks from all around the world with similar interests, where somebody will post, hey, I'm interested in doing this kind of study, and you can get institutional support and other experts kind of within the field as well, if you're interested in doing more of that.
I usually try to make the point of this series to like have students practice critiquing and presenting research articles. This time I chose one that would kind of strike up a good conversation and was fairly vague, so we could really delve into it. So less of a strict, rigorous research project and more of a discussion stimulator tonight.
Yeah, and so I guess my question, being not clinically experienced for you all, is there a difference in terms of your management of a patient coming in from a drowning if they had been submerged underwater with an entrapment for a long period of time versus someone who had this sort of face full of water over and over again? If both are drowning victims, what do you do? Was it different, I suppose, is the question? Or is it just drowning? Is that sort of, from a clinical perspective, drowning is drowning?
Yeah, they'll leave this up to Justin if you're about to go there.
No. I don't want to steamroll, but yeah, I think that statement, it's just drowning, is probably what I've closed most of my letters with, and most of the depositions that I've done in a lot of these cases when they do wind up in litigation, or when you're seeing it as a patient, is anything that distracts from that final common pathway, as Andrew said, of hypoxia, is a distractor. And then obviously you focus on the context, right? Was there entrapment? Was there trauma? Was there hypothermia? Was there hypoglycemia that precipitated it? Was there non-accidental trauma in a child, right? Just like you do for any other trauma or any other injury that you see, right? We see the DKA and we say, okay, it's DKA, but what precipitated it? And what underlying cause do we need to treat? Yes, this was drowning. Our immediate field treatment is going to be the same. It's going to be ABCs with a focus on the A and the B. And then going from there to identify traumatic or other medical comorbidities and such like that. And that's part of the umbrage that we take with some of these other definitions, is that they can, even if we're focusing on saltwater or freshwater, can sometimes take away from the importance of that final common pathway of cerebral anoxia.
I guess we kind of did talk about the flush drowning article as well. And I guess unless we want to more thoroughly talk about that in the response article that you wrote. But anything more to add about flush drowning or cold immersion?
Wear a life jacket. Most people hyperventilate themselves to death hitting in the cold water. If you want to check out, it's a few years old now, but the Cold Water Boot Camp was a really good series. It's, you can see free on YouTube. But most people hyperventilate themselves to death in the first 1 to 3 minutes. So wear a life jacket. Yeah, I'm a total Giesbrecht fanboy. I have a picture of me like with my arm around him like this at a conference, like taking a selfie, like it's Gordon Giesbrecht. Like nobody cares but me. But yeah, and then the adaptability of the cold shock response by habituation can fatigue with time. So the Navy SEALs and other athletes do this regularly, but a few months out of training of it, and you lose that that immunity to that cold water, and so it requires regular training.
That's really helpful. I don't know. I feel like I know a lot of paddlers who do swiftwater rescue courses. I haven't heard of folks doing anything like this. It sounds like it'd be really helpful. Have you
done cold water training?
Mm-hmm.
I mean, other than my swim last weekend, where it was freezing.
Accidental training.
Because it's like cold water is cold water, right? And that I think even when you're in a dry suit, it's just like, it's still going to shake you. I think the bigger thing that I experience when I'm in cold water and upside down in cold water is that your like brain stops working fairly quickly. And I have no idea what physiologically happens, although I'm sure Lauren could talk more about that. But I think the thing that's interesting to me for flush drown for this topic is, I think everybody that I know that has seen or been a part of a flush drowning, it's the shock. And I think in terms of like shock, like she was fine, she had air, I don't understand. And so I think in terms of prevention, having more conversations of like, you can be above water and still be at risk of drowning, and being able to get that messaging out to the public, to talk about like how drowning is usually a very quiet process. The video of the flush drowning in the Pacific Northwest that Lauren has in her slides, it's very quiet and it's very hard to notice. So yeah.
All right, I think that's all I had planned for drowning tonight, unless anybody has any like final tips or points they want to get across.
Great job, thank you. I'm sure you could figure out, we could stay on for 16 hours and we would never tire of hearing ourselves talk.
I mean, I guess I don't work till 2 p.m. so I can stay up late. All right, so this is the first in the 6-month series that's like planned out through the WMS. The next one is February 24th. We're covering pit viper envenomations. So we're going to kind of switch things up a bit next time. I'm going to try and see if I can get kind of a cool panel of experts from here on out. I'll try. I'm lucky that I know some of the people that joined us tonight. Hopefully I can figure this out for next time. But I'm going to keep track of the attendance. We'll figure out a way to submit the recording so then anybody can watch it again or spread it to anybody else that wants to join. And then, oh, don't worry, Gina. I know somebody who knows Ben Abbo. There's 2 people already saying him. We'll make sure we get some cool stuff going on next time too. And then if anybody wants to present, there's registration links. I know a lot of people have. I'll email you when I get to it. I'll try and get to it soon. So thanks. We're going to have a little breakout group of a couple people that I've already set up. So anybody else, if there's any other closing remarks, we are done. Thanks for joining.